are checking your screen name. Still have about 40 seconds. Start here shortly. Good evening to everyone. All right, good evening to everyone. Go ahead and turn your cameras on. Place your name and campus in the chat. Go ahead and check your screen name. Make sure that it matches how it appears on the roster. If you need to change your name, let me know and I can walk you through that. Give you a minute or so to get that done. Looks like we may make you all know what I'm going to say is happening, right? A storm, yeah. And so, but it's kind of lightening up. So hopefully we can make it on without any delays or problems or anything. But nevertheless, place your name and campus in the chat. Go ahead and check your screen name. Ensure that it matches the roster. We don't want any question about whether or not you and I were here. Sometimes when you're logging in with a different device or I don't know, these devices have a mind of their own, it'll revert back to whoever used it last, first, second, and third, all of that. If you are experiencing any issues, and that's any issue, put a message in the chat to myself. Don't send it out to everyone so I can know what's going on. In the event that my connection stops, just stay right there. I'll try to log back in if it's safe. But like I said, it seems like it is lightening back. The lighting is not as dark as it was over the last 30 minutes. So I think it's passing on through. So good evening and welcome to is this week 3, 2? Where we at this week? This week 2 for you, all right? Y'all better know. You should know now. You're almost there. Almost there. So I'm gonna share my screen here in a minute. And we will see where we're at and where we are going. Are there any questions before we actually get started? So by now should have placed your name and campus in the chat. You should have checked your screen name to ensure that it matches the roster. Are there any questions? Are there any questions so far? Can you check the chat? Make sure I don't have any there. No questions there. All right. Well, let's get ready to. Is there a question?
Should everyone put their name in the chat?
Yes, everyone should always place your name and your campus in the chat.
Did you want everyone to put? Yes.
Yes, when you're logging in on anyone's Zoom, always put your name and campus in the chat and check your screen name. Make sure it matches. Matches what your name, how it appears on the roster, you all. That's for class, that's for reviews. Even if we're meeting, if we're just meeting, just go ahead and just do that because we want to have that record if we have to recall anything. And as always, these sessions are recorded and they're viewed by the attendance administrators. Make sure that you're in an approved area. We don't want to violate HIPAA. We want you to be safe. We want those around you to be safe. So if you're in an area where you may need to log off, just send an email. We want to make sure we're following protocol and the expectation. If for any reason you have to be off the screen, just please let me know. Send a message in the chat. And if you're having connectivity issues, go ahead and put in the chat that you're having that. And just send it to me so we have a record of that as well. Any other questions? All right, so we are down to week 2 for you all, but it's week 8, but it's week 2. And then I'm going to share my screen here. So we're meeting tonight, and then we will also meet on next week. So our agenda, let's go to next week. Next week is we meet, we review shortly, like maybe like an hour or so, and then we have our exam. And then you don't log back in after exam, but we do a brief review before we actually take that exam, like an hour, maybe a little bit over an hour. Then we take a break and then come back. So, and that's just to let you know how that goes. And then, of course, week 10, we do HESI prep. You'll receive further information about that. Week 11, you all are HESIs. For the most part, how it's been for the last couple of years is all HESIs are in week 11. There might be a few exceptions. And know that those HESIs are campus specific. A lot of times, the day and time that your class originally is, that's the HESIs are the opposite or just a different day, so to speak, in time. So um campus dean should be reaching out for sure week 10. Sometimes they reach out as early as the end of week 9, but for sure 10, because you do take those HESIs in week 11 and they're campus specific. So when you're discussing amongst your coworkers, just make sure that you are writing down and noting information that's specific for you and your campus. And you want to verify that you verify with your campus dean. So next week is exam 1, so to speak, or exam 3. And so in the event that you want that exam proctored, and this is for any of your classes, you have to get campus approval. Not all campuses allow on-site proctoring, but in the event that that's something that you do want, and have that conversation with your campus dean, you all will have to decide on who is an approved faculty. The campus dean has to approve that, a day and a time, and all that information should be placed in a email message and include myself and then the team leader, which is Professor Cutler, and whomever your campus dean is. So just to let you know about that. If you have accommodations by now, you should have submitted that. But if you have not, make sure you also send that message as well. I just want to make sure that all of those things are provided for you. Yes, if you're having connectivity issues, please make note of it in the chat. So when we review, they'll know what was going on. All right. So, any questions about your schedule? And then, of course, week 12, you all. This is Tuesday. This is Wednesday. So we'll let you know closer to, because I've seen in the past where we do have to meet for attendance for week 12, and you do want to meet. We don't usually meet that long. Not even a fourth of your class time is very short, but you do have to meet for attendance purposes. And Wednesdays are kind of iffy because sometimes campuses, they do want um, all grades in by a certain time on that Wednesday. So in the event, if that's the case, we'll let you know what some alternate dates and times that you can meet, and so that you can make that attendance, because we don't want you to miss your attendance. So you'll get more information on that. It just depends on what time the campus is closed. Now, I know, like next week, if you all have Monday classes, is Labor Day next week or the week before after? So I don't know. Just taking that account. No, it's not next week. It's July. I mean, August doesn't end until that next week. So your teachers, that your professors, they will actually give you instructions on that if you're having to miss that week, and if that's an exam week. Anyone having an exam on that Monday, because that would be week, what, 10? Anyone have any Monday classes? So if you do, go ahead and be reaching out, because that's like one of those holidays that I think all campuses observe. So you should be getting information about what that's going to look like for you. Hopefully it's not an exam that week, but if it is, there's still some alternate. They have a plan. So no worries about that. So you should be getting guidance on that. All right. So let's move over here to let's look in our Canvas here. If you have not subscribed to your Outlook mail, make sure you go ahead and send a help desk ticket, because you are missing communications. You have your mail inside of Canvas, but you also need your mail for Outlook. You need your Outlook mail as well, because sometimes there is information that is sent that way. So if you have not been if you have access to it and haven't just been looking in it, make sure you actually start looking at it because there's information you more than likely are missing here. All right, so this is in your announcement section. So everything is pre-uploaded to your course here. So you want to look at your Kahoots, you want to look at your HESI concepts, your study resource, your exam review PowerPoint. All these things have been there. Medications, your list, and then week 7, 8, and 9. All of your information has been here. You do want to, the HESIs are coming up, in addition to your unit exams, go ahead and rewind. This is for all of your classes, information from that first week, and just make sure that you are looking at all of that. Because remember, NCLEX and HESIs, is everything. Your unit exam is just that coursework that we've covered, that we've actually covered. So make sure you're going back looking at that. And just look at the outline of the assignments that you have. You have your PowerPoints here. And also you can look at them. Am I in the module view? Yes. Well, this is the announcement, but you can actually click over to the module view and scroll down because it's all together here. But just go on down to, that's the maternity block. Go down to your mental health block. And it's the same information, but if you want to look at it in a different format, it just says week 1, which would have been last week, and then week 2 is where we are here now. Okay, so that's where we're at, and that is where we are going. All right, so we want to hit the ground running tonight. Is everybody okay today? Everything okay? I know we have some with the connectivity issues, and like I said, just make a note of it. Even me, if I lose connectivity, just stay right there. All right, so want to do a little short group activity. I'm going to place it in your Canvas mail. It's not there yet. I'm going to actually pull it up here and I'm going to share with you shortly. So just give me just a moment to place it there. I will let you know when it's actually there. If you're having to leave prior to the end of class, make a note in the chat to myself. But Zoom actually captures everything anyways, but still just make sure you put a note, and also you can send the email explaining why you left, but everything is time stamped. So my little connectivity is a little iffy right now. Just hold on. It is the little the weather. So I'm trying to load it up for you. I might have to close it out, y'all. It's spinning. I may just need to just wait. So just hold on. Seems like every Tuesday, Wednesday here lately, even on some Thursdays, it's been this weather. I think everybody's pretty much experiencing these different weather patterns. So, okay, so here it is. I'm going to actually place it in. It's pulled up here. Well, it starts spinning again. Wow. So what we're getting ready to do is we're gonna do 2 small groups, and it's just for the sake of just working together, discussing the concepts. And then of course we're gonna come back and share out as a group. And everyone will get a chance to participate because we will call on you by your group. We'll let you know who's um, we'll know who's in the groups and everything. So, but nevertheless, so you're getting together to discuss the slides that are assigned. And is this you all? Okay, this is you all right here. Okay, it's letting me attach it. Uh-oh, no, it's not. Hold on. Oh my. Okay, it's attached that time. So, and then in the subject bar, it just says activity. All right, so it is spinning out. It should come out to you. So hit refresh in your Canvas mail. All right, and so we're going to put you in small groups here for just a few minutes. And what you're going to work on is and talk through. Well, okay. So you have 10 slides. And what we'll let you do is we'll just do the first three slides. Okay, so click your refresh and hit your Canvas mail. There should be a email there from me that says activity. And you don't have to write on the slides or do a slide presentation, but you do need to have some notes. So when we come back and you're called on, you can actually discuss the actual topic or concept. So I'm going to open up the breakout rooms and we will look at the first five slides because I think the first slide is just the conversation. The conversation gets started. We have Nurse Paul and Nurse Jan. So you're going to look at the first five slides, do some jot noting so have some healthy conversation and be ready to share out when you come back. Breakout rooms.
Out of all 10 slides, I'm only able to see two.
Okay, so hopefully someone in your group will be able to see them as well. Do some jot noting and make sure everyone's at least in a group with someone else, and they are. So accept the invitation, go to the breakout room. Let me get my little timer here. So you're looking at just the first five slides. The first one is just the introduction. So we only need about 7 minutes. Not gonna take long. Let me get my little timer on. It takes a minute to do that. Accept the invitation to the breakout room. 7 minutes. We'll see you. Looking at just the first five slides. Get my little timer here, and there we go. Okay, everyone should be back within a minute, and we're gonna hear from you. Give everybody time to get back.
Hey, so
we didn't see any. We only
literally,
and it was one question, and I wasn't even. I'm not sure what we were supposed to do.
The question was, "What's the sign and symptoms of stress?"
Mm-hmm.
And that's the only thing I saw.
That's the only thing we saw.
Okay. Me too. Now, who is this talking to me? Because I'm looking at something else.
Good night,
everybody.
And Brianna.
Okay, so you can still maybe answer off cuff here. This is information you should have went over any, it's required reading info anyway. So let's see, do we have everyone back? Nope, just about 30 more seconds. And we'll have everyone back. All right, I think we have everyone back now. So I'm just going to spin the wheel and I'll let you know whose turn it is to go. And like I said, it's part of the required reading. So you should do well. Anyways, responding. All right, so it's telling me group number 3, and that is Sharp and Metcalf. And so we have Nurse Paul and Nurse Jan. This is all the places that we will go. They are getting ready for a huge community event on today. They're discussing all things patients, anything that you can think of. Because if you're out in the community, you just never know. I mean, you're having to consider the weather. Look at us today. We're having all these different weather events. You're having to consider, first aid, how many people do you have, everything. And also, we want to consider the mental well-being of everyone that will be actually participating on today at today's event. And it says, let's get ready to do our assessment. So we're doing one-on-one with patients, people that are coming in. And it says we need to do a mini mental, a body audit, and it just says list 5 things that to keep in mind as we're doing the mini mental, either the body audit. So we will hear from, let's see, what was the group that I say? It was number 3. So that's Sharp and Metcalf. So if you would just give us, we're doing a mini mental. Tell us 2 things that we should consider or think that we should be asking if we're doing a mini mental.
Well, first, we were saying that we should look at the patient's appearance and behavior because they might not want to be bothered. Sometimes appearance does say everything, especially dealing with a patient that has mental disorders. Um, After introducing yourself, we were saying, as far as their attitude, how they respond back to, like, say, for instance, if you ask hey, good morning or good evening, how you doing? As far as their attitude back, how they answer, which will also determine if they'll respond to you or how they might lash out. Um, what was appearance?
You can look at for their level of consciousness and orientation. So that'll give you, your person, if they know their person, place, time, or situation. So your A's and O's. What else? Well, you said how many? Did you want all 5, or you just wanted?
But y'all just keep going. Just keep going. Y'all are doing well.
Because I was
Just
about to
keep
say, I
going.
think she gave like 3, and I gave 4. I mean, 1 to make 4. That's enough. Go on to the next one.
Okay, so we'll spin the wheel. We'll let another group respond. And so when you said their voice, so these are all things that we need to be considered because we're out in the community. We don't know these patients. And so
Mhm.
we haven't established that rapport yet, which we're going to talk about in a few minutes. And so you want to look at all nonverbal and verbal. Eye contact. Oh, I mean, let me be quiet. Okay, hold on. Let me let one more group talk and then I'll jump in if I need to because you all may cover everything. You all have done well so far. Okay, let me see who's gonna go next. So again, we're in a community and we're getting ready to have this event. And so we're trying to think about everything from A to Z because we're trying to be proactive. And it says number 5. And so that's C, Smith, and McDuffie. We're in the community. We're going to conduct a mini mental, a body audit. And then also at the bottom, it says also consider the patient if a patient might have experienced violence. So you all can speak to any of those. Just list 3 points from that.
All right, so we said look for bruises or self-harming marks. Ask the patient if they're having trouble relaxing, being restless, or if it's hard to sit still, or if they have trouble with stop worrying.
Okay. Anybody else from that group?
She just said it
I
right.
did all of them, yes. And Keisha had trouble with her internet. She real choppy.
I can't see the slides either, but
Yeah.
I go back.
So I was just gonna speak for everybody.
Okay, great. So again, we want to pay attention to everything that's verbal and nonverbal. In addition to that, I think did someone say considering, and that may be another question, where we are actually at. So as you're setting up this, and even if you're inside or outside, you don't want to consider because remember, this person is getting ready to tell you personal information. They might have a mental illness, they might not, but still, we want to make sure that things are private as they can be. So as we're sitting up and we're having a station for a mini mental, for sure, if we're looking at people's skin, we need to have it in a private area where people are not. It shouldn't be next to the restrooms. It should not be in the area where there's a high traffic area. So we want to make sure we consider that as well. We want to keep the environment as calm as possible.
That was like more slide number 2.
Oh, I got it. I see. I just need to be quiet and let y'all just go ahead. Then I be trying to get ahead. I'm sorry, y'all. So mini mental. Let me go back to that. Evaluates the patient current presentation. You want to look at their appearance. How are they dressed? It's raining outside. Well, we're raining. I don't know about that. Let me give you a different example. It is scorching hot outside. The heat index is 115, and this person has on a wool coat, a little cow hat, gloves, and all of that. We want to look at their appearance, their behavior. As you're talking to them and you say, hey, I need you to complete this form, does it appear that they are understanding the instructions, the information you're giving them? Because if you're saying fill out this form, then they're going over to another room and they're coming back. So are they oriented and understand what you are actually asking them to do? We may have to change up our verbiage. The mood, happy, sad, they frowned, are they being aggressive? Is their speech garbled? Is it clear? And then their thought process. It's like, okay, we have to move the station from this state over here to there. Or if I ask you, if I state it's raining outside, what comes to mind? And most people say umbrella, rainbows, and things like that, but they say like a camel or pillow and things like that. Well, pillow because we kind of snuggle when it's raining. But you're just trying to see what their thought process is, their perception, their cognitive actual functioning. Now, what's that information that we need to know about them as we're gathering this information? I'm trying not to say it. As we're talking to them, we're going to be asking them about what?
History.
History. Yes, we want to know their past hospitalizations. We need to know their family history, their history, medications, diagnosis, and all of that information. Even with their medications, the ones that they are currently on, medications that they have been on, and then if they're not taking them, wow, we need to know we need to know all the business, the good, bad, and the ugly, because for sure we don't want them to, in the event that the healthcare provider wants to put them on something and they've already been on it and they may have bad results with it. We don't want to, put them back on that, that medication. So we need to know all of that. Their environment, we want to make sure that it's a calm, low stimulated environment, especially if we know that the event that we're having specifically is for people that might have mental illness or some type of issues with cognition. We do want to make sure that the area is private. Okay. So I think the next slide asks about, he says, don't forget about rapport. So let me see who's going to tell us about rapport. Let me spin this little wheel here. Rapport. What's that good old rapport? Let's see who's going to tell us all about it. Okay, so Sanders, Mathis, and Morset, if you would, please tell us about what is rapport? Rapport.
Having a conversation with the patient, likely getting to know them, like establishing a kind of sense of trust between you and the patient, making the patient a little bit more comfortable to answer questions rather. Basically building a trusting rapport environment for the patient to feel comfortable to answer questions.
Okay. Anyone else from that group? So someone else from that group, tell us about what do you think rapport is? You may say the same, maybe just word it differently.
You can show empathy and respect to the patient. Just being patient with them when you ask them questions. Not rushing them, allowing them to kind of gear the conversation.
Got it. Good. It promotes that honesty, giving them that time, and it shows that you're really invested in their well-being if you don't like rush them through it. So now we do have to ask, some questions that are kind of private. So just make sure that, we just ask those questions directly. And if they need clarity, we say, hey, if you don't understand, what I'm asking you, just let me know. And if I need to come back to this topic, let me know and we'll come back to this. And so, and like I said, it does. So that's good. Promotes that honesty, that trust. It builds that therapeutic relationship. Good. Thank you so much. Let's see. What's the next slide, you all? I want to get ahead.
Symptoms of stress, signs and symptoms of stress.
Okay, let me go back to, so when we're sitting there, we're conducting this mini, middle, and this body audit, we're focused on that person. We're, everything else blocked out. Hopefully the team knows that, you're in with this patient and they're not constantly interrupting you. Now, if you're that leader of the group to that day, you might want to limit like the number of patients that the activities and tasks that you complete, because you're going to have to be troubleshooting, putting out fires, and you're going to be that go-to person for that day. But we do want to use that client-centered approach when we're doing that interview. And then allowing the client, because sometimes we ask these questions, but sometimes they veer off on other things. So we'll allow them to voice their concerns, because we may have, for one, asked the question and they didn't realize that's what we were asking about. And two, they may want it to just elaborate a little bit more once they've settled in and they feel comfortable with you. So this allows for just a more comprehensive understanding of what the client needs and what their preferences are and what they're actually experiencing. Okay, so you said, Nurse Paul, this is an easy one for you, Jan. What are some signs and symptoms of stress? All right, let me spin this wheel. Signs and symptoms of stress. Who's going to tell us about it? Okay, looks like it's group 7. And that was Brown, Katona, and Kia.
For signs and symptoms, we had a headache, fatigue, irritability. What else was it?
Increased heart rate, blood pressure, fatigue, trouble concentrating, appetite changes, GI upset, and I think you've already said restlessness.
Okay, did we get them all? What about those muscles?
Sleeping.
Okay, what'd you say?
Muscle tension. We said muscle
Yeah,
tension.
they said muscle tension.
Muscle tension, okay. And where is that muscle tension usually at?
Mine be in the neck.
Yeah,
that's
mine
correct.
usually, it'd be head,
Neck and shoulders. Yep,
that's why I say mine
And
is
shoulders.
heavy.
Yes, neck and shoulders, that muscle tension. All those. And you were saying something about sleep. I'm sorry, you were saying they would say what about their sleep?
Difficulty sleeping.
Exactly. Falling asleep, staying asleep, all those parts of sleep. Yes. Okay, great. All right. So Lisa asked Nurse Jan about problem-focused coping. Lisa was told by the therapist that she should, and this should be this. Okay, so Lisa's the patient, and I'm just making this little stuff up. And these are your required readings, and I'm just pulling it, just trying to make it lifelike, so it can, seem kind of more real to you. Because for the most part, it kind of helps you with understand the concept. So here we go, guys. Lisa, she's a patient. She asked Nurse Jane. So Lisa and Jan are talking. Lisa says, "Hey, the therapist told me," and they're gonna come back to you because you're the nurse, even though the therapist told her. That's probably who she should have asked. They're going to come back to the nurse. So the therapist told me about problem-focused coping. What is that? What should I be considering? So this is what Lisa's asking.
Fixing the problem.
Who is that talking? I can't see who it is. Who's that talking? Miss Brittany. Okay, go ahead, Miss Brittany. Tell us about it.
Huh? I thought I was just answering the question.
Yeah, go ahead. Well, I didn't hear what you were saying.
Oh, I said focusing on fixing the problem if you can, or if not, finding mechanisms that can help you fix the problem. Coping mechanisms.
Okay. Problem focused. Some things are what they really say they are. It's problem focused. So you're right. Finding out, first of all, identifying what is that problem. Because a lot of times it's really not what you first think of, or you might think that it is. And after you talk, establish that rapport, and you can continue to talk to that patient, let them, explain and collaborate a little bit more. Then you find out what the problem is. Okay. Then see what we can do to fix the problem, resolve the issue. And if not, then the patient themselves seek out resources that can assist. And then know that sometimes it's in stages, because a person that has like negative self-talk or have bouts with depression, it may take baby steps or several moving parts to work up to that part where they are, not having those, when they do have the negative self-talk or thoughts, that they're able to just move those thoughts on out the way pretty quickly. But over time, those different moving parts will help them to be able to rebound pretty quickly, positively.
Like the 5 steps of grief.
Do what now?
Like the 5 steps of grief, like denial and
Yes.
Yeah, yeah, they got a
And
little.
you can go back and forth in that, and it's but identify that grief is the problem, and then what are those coping mechanisms? Yes. It's sort of like that PDSA cycle where you just kind of you can go through it and then you might have to go back and forward. But yes, great. All right. So what was the next one? I think you all only looked at the first five. Did you all look at the rest of them? Do we need to give you more time? Or did y'all go ahead and look at all of them? Yeah, I
I
probably
only
looked at
looked at the first five.
first
We
five.
got up
Okay.
to about 7.
Okay, so what we'll do is we're almost at our next break. So we'll just spend the next couple of minutes. We'll just let you all, because you all do good. You all were collaborating. And once I got around to see, we're talking mostly about the concepts and bouncing ideas off of each other. And so that's good. And so you do want to test this out. A test taking tip. Is this group thing a good thing for you? It might not be. So this is your opportunity to test it out. Also, an opportunity to validate what you think you know about these concepts. And then if you find out something, oh, I didn't know that, you need to be writing that down. So these are just good ways or different strategies that we can use to just layer it on. You're just there to review the content. Okay, so rest of the slides, let me mix you all up again. Let's see,
I
recreate.
can't see the rest of the slides.
I've only seen the first two.
Okay, so hopefully someone in your group can see the other ones and you all share. So we'll kind of make the groups where there's enough, at least one person in the group will be able to. So you do have the share mechanism, you all. It's that little square on my screen is a square with an arrow pointing upward in it. So make sure you share with the group. Don't want to put too many of you all in the group. So three should be enough. 3 or 4 should be enough. All right, here we go. Bring you back in 7 minutes, you all. Just look at the rest of the slides. And then we're going to bring you back and then we'll go to our first break. So accept the invitation to the breakout room and then look at the remainder of the slides. Let me get my timer set here. Okay, about 40 seconds. Everyone should be back and we'll actually toggle on over to our first break once everyone gets back. And then once we get back from our break, we'll hear from you all. 20 more seconds. Just a few more seconds.
Dr. Ford,
Yes.
before we get started, I don't want you to call in our group because it was me, Sanders, and Town, if I'm not mistaken. You said that you was gonna put us in a group of people that could see the PowerPoints. Well, ain't none of the 3 of us could see the PowerPoint.
Uh-oh. So that means y'all, it's challenge time. Challenge
Well,
time.
I sent text messages to people, but
Challenge
somebody
time.
on here, I'm not gonna call no names, text me back when we just came back talking about some. Oh, I tried to use my resources. It didn't work.
Well, we gonna see if y'all get y'all required readings, Miss Sharp. But no fear. This is a
You
safe
might be
space.
able to see it now. I had put it into the chat, so maybe everybody can see it now.
No worries, Mr. Summers. Thank you so much. We got you.
When you put it in the
team
chat,
got
I
you.
still can't see it.
You still
That,
can't see it?
I can
that's
only see
okay.
2 PowerPoints.
That's okay.
Really?
We got you.
Yeah.
I'll read it to you. All right, let's go to that breakout. We'll be back. I know y'all are excited. Y'all are doing so good. It's just beautiful to see the spirit of teamwork and up for the challenge. Woo, I ain't worried. If I see you the nuts coming through the door, I ain't gonna be worried. They're gonna take good care of you. So we'll see y'all in 5. See you in 5. So return 6:38, 6:38. See you in 5. Get up, walk around, go get something to drink or eat while I move around.
I'm gonna go to the store.
All righty. Let's come on back. Okay, I saw your message. Okay. All righty. So I'm just gonna sit back. So who was that volunteering to go ahead and start the conversation with those last couple of slides? Oh, I can spin the wheel again. Who wants to volunteer to start? Or I could just go ahead and do the wheel. Let's see, where's my little wheel at here?
Well, our group can start.
Okay, and what is your name?
Group five. Group 5, last name Likes.
Likes. Okay, let me go to that one. So I can take 5 out because otherwise I'll spin the wheel. Wait a minute, let me make sure. Y'all know I'm kind of slow with this. I don't know if it's the internet or what it is. Okay, so this is like Cease and Mathis, correct?
Mm-hmm.
Yes, ma'am.
Okay, so I'm taking group 5 off my wheel. Okay, go ahead.
Which one we starting off?
Well, I didn't have access to the I don't have access to the slides, but I think the first one was something in relationship to making sure what we do when talking with the patient. Brittany, you have it. Can you read it? I can answer it, but can you just read it for me?
Hold on. Oh, wait.
The first question.
I'm pulling it up. Sorry. Oh, you got to breathe? I'm sorry.
Go ahead.
All right. It says, Paul states, when assessing our patients, we want to remember this blank when talking to them and discussing diagnoses, signs and symptoms of medications, and etc. Bree said layman's terms, simple terms, and plain language.
And I said to be mindful of our body language, being respectful to the patient, making sure that we are positioned in a like in a welcoming interview position, but comfortable for the interview, and not threatening or intimidating.
And so that might mean sitting instead of standing, offering, it might mean both of you all are sitting, and also sometimes it just depends on how the room is set up across of each other, or either, parallel, however, but yes, all spot on. Make sure we're speaking in terms that they can understand. Because remember, sometimes these terms, we even have problems with them. So just imagine a person that hasn't studied, medical terminology. So put it into terms that they can understand. So instead of saying, your anxiety, do you have anxiety? What other word or how else could we phrase that?
We could start off by asking them, number one, how are they feeling, to get a generalization of what they could be on,
Or asking what have they been experiencing lately? Have they had any
I've been feeling nervousness or stuff like that.
Yeah.
Or have you been sleeping well?
Headache, muscle tension.
Yeah.
Okay. Got it. All right. Let me spin the wheel. Thank you all. Okay. So here we go. Thank you so much. Put put that information so they can understand it. Because it's almost like, for example, if the patient speaks German and you speak Spanish, they don't know no one's know what the other is talking about. So, all right, group number 4. Let's Sanders, Town, and Sharp. Take it away.
Our group didn't have no slides, so we don't even know what we're supposed to be answering.
Okay, so tell us about lithium, lorazepam.
Fluoxetine.
Oh yeah, and that one, Prozac, yes. Tell us about
Do
it.
not stop abruptly. Report any side effects, shivers, monitor shivers. Lithium mood stabilizer, increase fluids, fiber. Monitor liver enzymes and kidney. Lorazepam, no alcohol. Sedation, dizziness. It's a benzo. Used with caution because seizures, withdrawal, and respiratory depression. I just help y'all out.
All right. Thank you so much. And here we go. Uh-oh, was someone else talking?
He just said thank you.
Oh, okay. Yeah. You're welcome. All right, so let's see. That's number 6. Brown, Jacobs, Katana, and Marset. Now, Paul, I have panic attacks sometimes, but what has helped me is what are some non-pharmacologic interventions you think Jan is saying? Just thought you should know who you're working with, stated Jan. Okay, go ahead.
Exercising. Like breathing exercises. It broke up
Breathing
a little bit.
exercises.
Oh yeah, breathing exercises. What we said, journaling.
I could hear them, but I can't really hear them. But I think that is what they said. Journaling, breathing exercises.
Breathing exercises.
Say that one again.
Visual exercise, walking, jogging, journaling. Walking, jogging, journaling, and visual exercises.
Okay,
visual things to take their mind off of what they're dealing with.
Okay, great. Okay, next person, next team. Paul states, I think OCD and panic attacks are somewhat familiar. Jan states, what? They both are different. Let's talk about this. So OCD and panic attacks. Let me see who is going to share with us on that.
Can I volunteer?
Of course. Who's that volunteer?
Janaya.
So what's your last name, Janaya?
Smith.
See, can I find you your team? So Bolton, Smith, and Benson. So let me take you all out. I removed number 2. Okay, go ahead.
So OCD is more so like an obsession. And then you have compulsive, like they have to do it. Panic attacks it's like an intense fear. Like they just so like say for instance with people with OCD, they do things to like calm their anxiety. So like say for instance, we see a lot of people with OCD clean a lot, and that like, calm their nerves. It just relaxes them. Whereas people who are panicking, their nerves is like hot. It's shot up. There's trembling, there's shaking, sweating,
dizziness and palpitations.
Yeah, they can palpitations. They can hyperventilate. Blood pressure can go up because they're panicking. But it's like the kind of polar opposite.
They are polar opposites, but they kind of resemble because obsession can cause panic. Does that make sense?
But even with them being obsessed, the OCD, their trait is to try to calm their anxiety. Versus the other person, they're so stressed out. They're
ramping up.
Yeah, and
one is trying to put itself down. The other one is they hyperventilating. They going like they just like.
But that's the action.
OCD is stress. It's a stress.
But the OCD is still a panic or stress. Yeah. It may not be the same, but they have similarities because if my OCD is a nasty house and I come in here and I don't have no mop, then I'm a panic about that. I don't know, just my way of explaining it. I think they're not the same, but similar.
Yeah, they both stress.
Panic attack is more compulsive.
Yeah, the difference is OCD is not going to cause you any physical harm. When they panic attack, it's going to cause a physical reaction.
Yeah, your heart rate going up, hyperventilating. You can
and OCD is repetitive behavior.
So like
they have overwhelming.
But when you have OCD, it'll kind of lead into you having a panic too, though. Like if it don't go your way with OCD, you have a panic.
Disorders, but if you look at the kind of dictionary of it, one is pushing the stress down, one is pushing the stress up, but they're both stress disorders.
Yeah.
So we
So
agree.
like what,
Let me
like you
interject
said,
here.
OCD,
So let me
they're
interject.
gonna panic until they kind
No.
of do the action that that's intruding.
Miss Mathis, great. Y'all had a great conversation. For the most part, you didn't really overtalk each other. So you all are saying you agree with both Jan and Paul. So they're similar, but then they're not. They domino effect. So does a person automatically have panic attacks if they have OCD and vice versa?
No.
No, exactly. And so all of the things that you all are saying are correct. And that question was there because I need you to know what OCD and I need to know what panic attack. So make sure you do know the difference. And so no matter how that question is asked, you're able to pick out which one. Because those are the two that people sort of kind of mix up. You know, does one lead to the other? Does one automatically mean the other one will have it? So just make sure that you do understand it. Great conversation. All right.
So what's
now
the overall answer? Like they are similar or they're not?
they're
both.
not. They're not.
They're not
They're
similar,
totally
but
different. Go ahead.
Can I say something real quick?
Yes, go ahead.
So pretty much OCD is more like it's compulsive. So be honest with you, it's something that triggered the action. Like say you got to clean up something that's triggering it. But then you got difference between panic attack, which is more sudden. It's a sudden period, so something that pushed onto that attack that caused that panic. So it could be anything. So like something very very traumatic, something very very. So it's like it's pushing on that trauma.
They overlap, basically. They're not the same, but they overlap.
But they overlap, but they're totally
A
different.
person might not have both. So you still need to know individual what each one is individual because the person might have panic attacks, but they might not have OCD. Person might have both diagnoses listed there. There are some that's going to have schizo, bipolar, several diagnoses there. So you have to still know that they still sit individually, but you may some of the signs and they may domino effect and lead. The OCD may lead to the panic attack. The panic attack may end up leading to the OCD. So you may see that. It doesn't happen often, but you do see those multiple diagnoses there. All right, now who's gonna volunteer for this last? Nurse Jan states, I got this. Goals should be blank. This promotes a sense of accomplishments and gradual return to normal activities. What about those goals?
The patient telling you some good goals, like things that they want to accomplish when they leave.
So yes, what about those goals? What's something
should be attainable?
It has to be realistic.
Realistic goals.
Yeah, it's something that can be achieved. Not
got it.
And it should have some way of gradually increasing. So like if I wanted to walk to the store to get some exercise, then next thing I want to try running to the store. It has to be.
Wait a minute, you going too fast. We're gonna walk and then start running.
No. Let
me do a little jog. I know. So yeah, let me do a little jog.
Like stacking up like.
So yes, short, baby steps.
Baby steps.
Yeah, don't take me too fast now.
It has to be something that can go and level up
to a long-term goal.
And you have to say, hey, we don't want to go from crawling to running because even though they want to run, still you want them to maintain that steady pace moving forward. So you don't want them to not be able to run after 2 days and then just say, forget all of this, forget about the progress and all of that. So have that conversation. It's going to take you some time, and it's okay to say that. So let me sum all of this up. You all did really, really good. And then we're going to move on to our other slides. But let me just sum everything up just to make sure. Go back to your notes. Just make sure you do some jot noting. And I think I got the correct design this time. Y'all know I added in all my little colors and things. So I think everything will be okay. So problem-focused coping involves generating solutions to decrease or eliminate identified stresses. What is the problem? And then develop a plan to address that problem. Developing self-care philosophy is a positive coping strategy that includes setting limits. So setting limits, that's the thing that we tend to have a problem with, mental illness or not. For the most part, as nurses, you want to do everything for everybody because you want to provide that best care. So that's people at home, work, family, even at the mall and everywhere. So we want to know that it does include setting some limits so that we can maintain that personal well-being. So we as a nurse, the patient, if they're the patient and then they have people that are dependent on them, they're going to have to maintain their personal well-being. Otherwise, they're not going to do themselves or the people that they're responsible for any good. Addressing the source of stress by seeking out additional support and resources. It is okay if you do not understand what it is that you need to do. We can connect you with this resource, because that's what they are. That's what they're there for. Literally, that's why they are there. Because for example, and this doesn't, I guess it does have to do with mental health. Well, you know how everything that's going on in the world, people express, hey, we want to get back to gardening, or if they were already gardening, they wanted to expand it. So it's like, okay, what can we do? So, for the most part, we don't have acres and acres of land. Hey, you got a front porch, a back porch, you have a window sill. So we created containers or got containers, dirt, soil, all these things, so that these people that express that, so they can start. So you just have to just think outside the box sometimes, but nevertheless, it is attainable. So when assessing for anxiety or any of these disorders or any of even the OCD, when we're gathering that information and having that conversation with our patients, make sure we're speaking in terms that they can understand. We're studying to learn these things. So for the most part, they're gonna be just lay people. They're not gonna know these medical terms, but nevertheless, just speak in terms that they can understand. So the example that I have here is anxiety. Asking about anxiety or asking about worrying, or do you have are you experiencing this? So like lay out the signs and symptoms for them, or use a term that they can more than likely understand, because otherwise they're not going to know what you're talking about. They're going to say no to everything, but well, they answer no to everything. But if they can have that same conversation with someone else and the verbiage is changed up, like, oh wow, is this the same person? Yes, because they understand now what you're really asking them. We do want to build that rapport. It promotes honesty. The nurse must directly ask about suicide. It's to clarify risk. This question is usually on that intake form. Notice a touchy subject, but we must just ask about it. Of course, we want to be sensitive, making sure that we're conducting this in as private as we can area. Watching our voice tone, the pitch of it, and so we want to assess for plan, means, and determine the level of danger. Like, hey, do they actually have a plan? Because if they do have a plan, they're more than likely are going to go through with it. But nevertheless, we got to ask about it. Another question that we're asking now is, do you feel safe at home? I don't know if you all have done like these intake questions. They're asking about, okay, or do you have, I don't know if they say food, but that's what it leads me to believe. Do you have food to eat? Are you safe? Have you had thoughts of harming yourself?
One of the forms do ask that if they feel safe and do they have food.
Yes, so that's what we're finding out now. We need to ask these questions because we're finding out people are being harmed, they're being abused, and they're not eating or unhoused, and these resources are there. We can link them, even though they're coming into the doctor's office, they're coming into the ER for something totally different. But there's an opportunity to provide that best help and identify things for patients, resources. A client-centered approach involves flexibility in the interview. So sometimes, we're asking this question and we want to move on to the next question. Clients are kind of talking about whatever. We can refocus them, but we do want them to allow them time to express their concerns and their perspectives. So this helps us to gather more information so that we can provide that unique, individualized care plan for them. Personalized approaches allows for discussions about the diet, the health, everything. We find out more than we want to know. But the thing is, it allows us to provide that individualized care for them and also to be proactive. The patient is leaving our facility. We've already thinking about, their discharge, what resources they most likely are going to possibly need. So, of course, we always want to be respectful. We do want to be safe though, but we do want to demonstrate respect and acceptance and concern, and then offer clients that connection and then encourage them to talk in freedom. That's that rapport that we were talking about, that therapeutic relationships. So we talked about the mental status examination. This is where we're gathering all things about our patients. We're looking at nonverbal and verbal clues, And then we're gathering information about their history, their current status, their medications, everything. Because again, we don't want to be prescribing a patient a medicine or identifying a resource they already have tried, because there are some resources too in the communities. It's like time sensitive. So I think that's the correct verbiage. But if they've used it before, it's like a one-time use thing. So we want to know if they've already used that resource, because then it might not be available. So upon discharge, we're identifying this resource and they've already used it. And it's like, not any good for them. So we want to know all of that information. When assessing a client who has been a victim of violence, first obtain their consent. And then when we're looking at that, we're doing that body audit, we want to make note of, use when we're doing size, shape, color, and patterns, use just be as descriptive as you can. If they're, for example, quarter size, dime size, take out that ruler and actually measure stuff. Use common terms, purple, blue, things like that. So there's no wonder as to what actually has happened. Okay, go back. Had a message in the chat. Okay. Got it. So specific examples that raise concern include a history of trauma that are inconsistent and implausible with the physical examination. So we're fine. We have these findings. And it's like, wait a minute, you see these bruises, but you said you came in for a stomach ache. So that you find that, the patient come in with a headache, and then once you're actually having to start an IV or you're doing that body, you find these, you have these findings. And so that leads to more conversation. So you do want to make sure that that environment is calm, as private as you can. And, in the ER, for the most part, they have like these little curtain dividing us. So just make sure our voice tone, we may even have to, they have some rooms in the ER and in the urgent cares where they're a little bit more private. We may have to change that room so that we can gather more information. And then just be aware of, if someone is with them, if they're answering all the questions and not allowing the patient to actually answer. Muscle tension. You all say that this shoulders and neck, and is a sign of stress. Not being able to sleep, upset stomach, so forth and so forth. Children who have been subjected to neglect often have developmental delays. My little slide didn't, okay. Developmental delays. Move us over here so we can see the rest of it. Okay. Learning problems, passivity, low self-esteem, and social competency problems. They may lash out, respond inappropriately. And it's just a result of them being subjected to that neglect, not being housed, fed, taken to their well child appointments or their sick child appointments. All that includes neglect, not having, running water, being able to change clothes and things like that. And so that does impede their growth. It does affect their development. Hearing voices that others cannot hear is a type of auditory hallucinations. It's defined as a sensory perception in the absence of outside stimuli. I don't think I gave you all a slide on that, but nevertheless, we need to know it. Pressured speech is a symptom often associated with manic episodes. I think Jan and Paul stopped talking. I didn't give you all the rest of the slides, but I'll just go ahead and go through this. Pressured speech is a symptom often associated with manic episodes characterized by rapid, frenzied, and often difficult to interrupt speech. So these are just signs and symptoms. I think you all mentioned this when we were talking about one question. Did I give you all the question about medication administration? No, I did not. So, but nevertheless, we'll push through because we have a whole bunch of other slides to get through. So the nurse is prepared to administer medication. So I need you, I'm going to pause, I'm going to let you take about 2 minutes. Jot down on your paper what is the correct sequence, or if you already have it in your notes because you already did your required readings, go through and find it. You need to know the correct sequence of steps the nurse should follow to safely administer the prescribed medicine. I am going to put my timer on, give you 2 minutes to write your steps down. We'll talk about them here in just a moment. 2 minutes. Okay, 37 seconds, and we'll hear from you. All right, let me hear from 2 volunteers. What is your sequence? First volunteer, go ahead.
Right here, the 7 rights of administration. That's what I would follow. Dose route, strength, patient, medication, time, documentation, and the reason for the medication.
Right patient, right medication, right dosage, right route, right time. Same thing she said.
What was the last thing? I'm sorry.
Right time.
Right time.
I said the same thing she said.
Okay. So I always start by verifying the medication order for accuracy. So we checking that order, because even though there's an order there, sometimes they leave out, how many tablets. They may leave out the actual time of day, but just make sure that the order is actually accurate. Check for potential interactions before administration. The way they have these electronic records now set up, you can click and it'll just show you, if there's an interaction or there's a symbol or something there. We do want to assess the patient's current mental status to establish that baseline, provide patient education before administering the medicine. We want to administer the medicine following proper protocols, those rights of medication administration. We do want to come back and make sure that we're monitoring potential side effects. We want to document all steps. We got to document what we did, even the patient's response to the medication. Okay, because we're up to what, 8 rights or 9 rights now? Is it 8? Is it 8 or 9 medication rights? Let's see, right patient. Y'all help me name them off. We got right patient,
right drug,
right medication, right dosage, right route,
right time, right?
Right route, right time, right dose,
right assessment, right
routes.
Do you need a consent form?
The right to refuse.
Mm-hmm.
Okay.
Oh yeah.
All right, good. I think it was 8 of them. So patients, remember to remind our patients, hey, it's going to take a little while for this medication for you actually start seeing changes, or this medication actually starts to work for you before you start to feel better. Because we don't want them to abandon, taking the medications. Oh, this stuff, I've been taking it a week. I've been taking it 2 weeks. So just remind them, hey, it's going to take a little while, up to 4 to 6 weeks for some of it. And then even with that, we, don't just abruptly stop taking it. So we are mandated reporters. What does that mean?
You have to report certain things, like what patients tell you.
Okay, incidents of violence. Even if we suspect abuse, we don't have to know all the details, but we have to report it. And then you can report that anonymously. Then they'll do the investigation and everything. So victims of violence may experience disturbed relationships with family and friends as they attempt to cope with their experiences and rebuild their lives. So identifying help groups, non-pharmacologic interventions like journaling. What was the other thing that I said? Exercising. It was another one. Y'all said something about some light. Who said something about the light therapy? But nevertheless, identifying all of these resources for the patient, so that they can rebuild and so that they can be in relationships and conversations and have interactions that are appropriate, and so in hopes that they don't act out. Intimate partner violence, does it affect children? So you got 2 partners.
Yes.
Okay, so what effects did it have on that child?
If the child is present during that, it can create probably like
emotional abuse.
Yeah. They may have
nervousness,
relationships in the future.
They may have trouble sleeping and difficulty like eating full meals.
Correct.
They too might do violence. Use
Doing
violence.
what they have seen, thinking that that's the way to actually cope, and thinking that that's the way that it should be. There is a misconception that infants and young children are not affected. You all are correct. They are affected. And as with adults, the things that they are experiencing Move this out the way. And then over time, they may actually act out and do what they have seen like that. So it sort of kind of becomes like learned behavior, and because that's what they've seen to deal with, and so that's what they do. So it does affect the children. All right, so I'm gonna let you in the chat. Let's use the chat. Put a T or F. I'll give you a minute to just read through it and think about it. Just put a T or F there. Is it true or false? Just put a T or F. All righty. So, what would make this statement true if we change one word to what?
From increase to decrease. Change decrease to increase.
To increase.
Okay. Just take into make sure you're reading through, because that one word can throw what you're thinking also. Make sure that you're reading for clarity, reading what it actually states. So yes, this one word right here changed this whole statement. Got it. Okay. Depression, poor impulse control, and emotional isolation, turn our little timer off, are related to suicide in adults. So, they might feel that they, have lost control or don't have any coping mechanisms, don't know what to do, what their next steps are. And so they may act out. And then it could also lead to attempts to commit suicide. Asking clients directly, we talked about this. These are some questions that we have to ask. And asking clients directly about suicidal thoughts gives them permission to discuss their feelings, and it opens the door, hey, to tell you more, in hopes that they do, so that we can seek out resources for them. I'm going to come back to that side. We're going to stop right here and let's go on to a Kahoot real quick. We'll come back to those. All right, so let me pause and pull up our little Kahoot here. And then we have about 10 more minutes, and then we'll take our next break. Let me find this. It's making me log in, sending a message to my phone. So just give me another minute or so.
Quick question. You said the MSE is used to examine the patient's mental health status?
Depends on what setting you're in. They call it mini mentals, but nevertheless, that you're just gathering more information. It's part of your head to toe assessment, anyways. But they specifically, when our patients might be coming in for some type of mental health crisis, is ask more detailed questions, more targeted questions. Okay, let's see. It's gonna let me in now. And there are some other exams, they're similar to that, but they call them different things. And so, but nevertheless, is trying to gather more information about all things mental status wise. Okay. Yeah. Okay, now I'm having to download y'all. Just hold on. 2 more minutes. If not, we'll switch and move to something else. But hopefully it'll do what it needs to do. I'm not
Are
sure.
we doing the PowerPoints tonight or no?
Yes, we are. I'm not sure about the with these updates. You could have been just in your computer or inside of Cahoots 5 minutes ago, and it asked you to update this information. Who push out all these updates anyways? Here we go, y'all. Let's go. Let's go.
Can you explain pressure speech one more time?
So that pressure of speech is, I don't want to say it's garbled, but it's like that you can't get a word in. Uh-oh. I want to change my speech. Maybe not my speech, my language. It was asking me about my language. And so like they feel that they just, just gotta tell you, just gotta tell you, just, just on and on and on, just gotta tell you. Now it's not garbled because what they're saying is a line, because garbled is just like, it's almost like word salad, just pulling things out of the air. But it's, I gotta get you, I gotta tell you this. It was raining outside and and so they're not letting you in, they're not letting up for breath in between. Okay, here we go. They just got to get you the information right now without really even having the person that they're communicating time to actually receive it and understand what they're actually saying. Okay, Cahoots is trying to open it. Here we go. So word salad, it literally is like a salad. You have all these different things in the salad. Nothing's really, flowing. It's just a bunch of words. Like it's almost like garbled. But that pressure, it makes sense what they're saying. There's connections in their talk, but it's just they're just not letting up. It's just not giving that person that's receiving the information time to even digest it or understand it. And here we go. All right, so it's loading. Of course, we always review the PowerPoints. We go through the Cahoots and everything. You have your required readings. So identify those things that you're like, oh my goodness, what are they really talking about? Those should go at the top of your list to make sure that you go back and review it first. And then all those other concepts should come after that. Okay. All right. So I'm going to share my screen here so we can log into this Kahoot. At a minimum, log in with your initials. You don't have to put your whole name if you don't so desire. And I will go on mute and let you all think it through. All righty. Getting ready to start. And here we go. Wow, y'all are rocking. Sorry. Here we go. All righty. All right, so let's go back and see. You all did pretty good, but let's go back and recap. Chapter 36. Of course, you have all of your objectives here. Let's do the slideshow. So use those objectives and see if you can answer them. And that's a good determination of which concepts you need to probably go back, put at the top and go back and look at first, second, and next. Okay. So violence is the intentional use of physical force or power, threatened or actual against oneself or someone else or even a group. Okay. Interpersonal violence is when a violent act occurs between persons. So interpersonal between the two people. We must consider the recipient and the offender, along with the nature of the violence, the environment in which the violence actually occurs, and the relationship between the two people, and then the recipient. You know, who's all involved. These are just have the different categories here. You know, bullying is real. It is considered a category of violence. So what are those things that we might the consequences of it? Injury, sexual trauma, unintended pregnancies, violence during the actual pregnancy, and then intentional or unintentional death. We want to also think about PTSD because if this is deemed detrimental, stressful, that event could lead to PTSD. Mental illnesses can be exacerbated by exposure to violence. It may contribute to that interpersonal violence. Bullying, we know the consequences of it. It can be a person can have lasting effects from it. A person's life or can hang in the balance because of someone actually bullying them. I know the last thing I heard about bullying was like adults bullying children in the school setting. What was another incident that I've heard about here lately in the news where family members or even patients are bullying the nurse? You have the orders, you've done all the proper procedures to take care of the patient, and they're just after you. They're saying mean things, posting things and stuff like that. So it can occur. It can occur. So we talked about how it can affect intimate partner violence can affect infants and children. It affects all those that are involved, even if they are observant to it. It does affect, no matter what the age is. So populations at greater risk, everyone, regardless of age, gender, race, or ethnicity. So some individual risk factors: substance use. These puts a person at risk for if they have mental health conditions and if they have been exposed to violence in their childhood. So we always want to consider that social cultural. Where do they live? Where is their place of employment? Or, so what are their living conditions? Because those things, they do matter. So we're gathering the history, and we're going to more than likely do that skin assessment, paying attention to what they're telling you. And then that can lead your conversation to ask them a focused question, especially if you're seeing injuries that are inconsistent with what the reason they're presenting with. They're presenting with a headache, and then you see that the fingers are deformed, and it's not because of arthritis, it's a visible deformity because that finger might be broken or have been broken. So they might be afraid, especially if someone else is there. So like I said, be careful with the other person answering questions and now really not allowing them to answer. We might have to change where the assessment, the conversation is actually being held at. We want to make sure that it is as private as we can so that they won't be embarrassed or not wanting to tell you what's actually going on. So we want to be as descriptive with the injuries. We may have to measure, making sure we're putting down right, left, being as descriptive as we can. It may be an old or new injury, but nevertheless, we're going to still write it down when we're doing that body audit. So some common comorbidity conditions and injuries: burns from scalding water, burns with stocking or certain that are a circular pattern. Even if you're a fork, if you see patterns that are common, someone burned themselves, like on a flat iron or a stove or something, it has a distinct pattern. But if someone is being burned with a device or some type of object, it's going to usually take on that form. So just make sure that we're just asking those questions just to verify, what it is, and so we can identify some resources. So primary prevention education is designed to reduce the rates of violence, focus on individual, community, and societal changes. What can we do? So secondary prevention, that's that screening. And so we're asking those questions. Either we give them the tablet and they're entering the information themselves, or it's a questions that we're answering. Nevertheless, we are trying to detect and determine if it actually is occurring. So some collaborative interventions includes referring that victim to a safe house. They usually have them, providing that emotional support. And these are just some interrelated concepts. that might also we need to consider. You know, that coping is a huge one. Okay, let's look at it. We're going to answer this question and we're going to go to break here. Time for our next break. What is the term for abuse that consists of intimidation or domination toward an individual who is perceived as weak?
Bullying.
Bullying.
Is that your final answer?
Yes, ma'am.
All right. Bullying is a form of abuse. Bullying tactics can be physical, verbal, or emotional, often through social and cyberbullying approaches. It is real, y'all. It's not, it's nothing to take light. All right, so we're gonna pause and take another 5-minute break. Remember, this recording still plays, you all, but turn your cameras off and all of that. We'll see you in 5. So at what is it, 7:40? 7:40. So I don't see someone, but we can hear you. So make sure that you're on mute, you all. We don't want this thing to pick up, record anything that it should be. All right, let's go on to our next segment. We're almost there, you all. Push this one on up. Okay. So in the chat, just put 1, 2, 3, or 4. Excuse me, and then we'll check. You'll check your answer when I show you the next slide. So give you a moment to read it. Excuse me. And here we go. Okay. The victim is considered the recipient of the violence. One more question. On what continent is the social cultural view of the etiology of intimate partner violence rooted in the family and society in the form of a historical legacy of oppression and colonization? And you can just drop 1, 2, 3, or 4 in the chat. Okay, and let's check your answer. Okay, in North America, a social cultural view of the etiology of IPV, intimate partner violence, is rooted in the family and society in the form of historical legacy of oppression and colonization. I think that's our last slide. Okay. All right, so let's move on to chapter number 26. We're going to look at outward focused emotions violence. Slideshow. Okay, these are our objectives. Okay. So someone read this slide for me. One volunteer.
Human beings engage in aggressive or violent behaviors for a variety of reasons. Human reactions can be placed on a continuum ranging from calm to violent. Calm, anxiety, agitation, aggression, abuse, and violence.
Thank you. So no one is certain exactly why violence occurs. Nurses and other healthcare providers accept and care for all people, but this philosophy is associated with risk for violence. Aggressive and violent acts are committed by members of every group in society. Poverty sometimes could play a role, but there's no certain, specific reasons why they're saying, why violence actually occurs. So we do have all these theorists that looks at it and say, hey, study the social history, that's causing it. The way, humans have evolved over time. Social learning theory views aggressive and violent behaviors as learned by role modeling others in, the environment that they were actually in. So all these theories have tried to just identify and narrow down what is going on when someone is experiencing it and also the person is actually being violent. We have domestic violence and there's abuse and battering within the family, and dysfunctional family violence within the family occurs in several ways. Through neglect. Sometimes we don't think of that as being an act of violence. So these are just some characteristics of a family member that is dysfunctional. So they're not really sure of, what their role is, what they're supposed to be doing, when they're supposed to be doing it. Communication about it is doesn't happen. It may happen, but it could be disjointed. So and that authority is often inconsistent or just not even present. Okay, so there's no typical abused woman. Characteristics of an abused woman: trusting nature, raised to be non-aggressive and traditional, believes that the man is the master and protector of the household. Characteristics of an abuser of women. So the person that is abusing: poor emotional control, history of substance abuse, high levels of jealousy and insecurity. So someone read this one right here about what could be happening when with the child and the mom.
Abuse during pregnancy. For some women, pregnancy only increases their chances of being abused. The frequency and severity of abuse, as well as the potential for homicide, are significantly increased for white women who become pregnant. Effects can be devastating: low birth weight infants, preterm deliveries, lack of prenatal care.
And just know that lack of prenatal care could just, spiral into so many other things. The most vulnerable individuals in society is going to be our children. We always want to take care of our elderly and our children. But between those two groups, the child is going to be the one that's most vulnerable because they solely are going to rely on someone else, whether that's a parent or guardian, to provide what they need. The rate of abuse of adolescents surpasses that of younger children. Abused teens are less likely than abused younger children to receive the needed services and counseling, because it's like once that child becomes of that age, I don't know what it is, and you all may create a resource or be that for-profit or non-profit organization that creates something, but we do see it where the abused teens are less likely to get those resources that are needed. I don't know if it's just because there's not enough programs or education about that the programs exist, but we do see that. I know like in our areas the programs are just non-existent. So what are some factors that may cause, and we'll let you just kind of talk about this for just a minute or so. What factors may cause? Now, we're not saying that it's an excuse or reason to, but what factors may cause caregivers to abuse the person, particularly the older adult that they're supposed to be taking care of?
Lack of financial help, lack of help all around.
Being burnout. Being overworked.
Yeah, overwork, burning.
Lack of training.
Burnout.
Resentment.
Patient being combative.
Mm-hmm.
Okay. So vulnerable older adults, those with chronic or disabling illnesses, aged individuals, those who are poor or have fewer resources. Family members are most frequent, usually the ones that are there. They're usually there the most of the time. And they're the ones, like you're saying, that may be burned out, they can't identify resources, might not have the support that they need. And so usually those are the ones that usually are doing the abuse. So sexual abuse is that unwanted sexual attentions from another. Sexual violence has strong and lasting consequences for the victims. We're encouraging them to report any suspicious signs or behavior. This is a nurse to the supervisor and the required authorities. So, you might have to call, be it the nursing home, the long-term care facility. You might have to call in the police, if that's what's needed, so that an appropriate paperwork documentation is done so that it can be actually followed up. So today's society is confronted with a steady diet of violent behaviors. Acts of violence are becoming commonly accepted in society. You just hear about it so much. It seems like maybe like the last 10 years, it's like, what has happened? What is going on in the hearts and minds? Group abuse, aggression against certain groups, and so just want to make sure, when you're out and about, on your girls' trips, on your cousins' trips, and all these things, and your family trips, just making sure that we're aware of and aware of our surroundings and what is actually going on. And it was some movie that I watched, and the families were going on, and I can't think what the name. And I don't even know if it's a true story, but the person actually was mentally ill, and it was a male, and it wasn't a highly visited family getaway, but it was where families, and it was like partially wilderness. But anyways, the whole point of it, what I'm trying to say is, this person, they were mentally ill, and they were actually targeting the people, the families. And so the park ranger, this lady had come to visit, and he was like, well, you're by yourself. Usually families come here. And she made note of like all these missing persons that were on the wall. It's like, wow, these been missing from after coming here. I don't know what the name of that movie was. Well,
Was that book that was based on like a game?
That sound like a movie. Were they in the mountains, like in a snowy area?
I don't remember snow, but it was like mountains, I think. I don't.
And then the friends came looking for her, and they got stuck into the thing too.
I don't know how I think she got out by herself, because the lady, now the other family members, these families, they found it out this after she actually got away, that this person had been targeting these families, but she didn't have any help. She had, I guess, all these different types of training. So she was in the wilderness. She knew about how to, cut this plant and, make them smoke and all these different things. I don't know if it was based on a book. I don't know. I just remember how this person did not get the help that they needed for their mental illness. And they started targeting families that were going on trips. So just make sure that we're just being aware of our surroundings, you all, because evil is real. And also, if a person doesn't get the assistance and the help that they need, then that turns into acts of violence. And no one is exempt. Families, children, no one. So the DSM-5 defines only one clinical syndrome as directly related to violence, and that's post-traumatic stress disorder. So rape trauma syndrome, a nursing diagnosis that encompasses the essentials of care for victims of this violent experience. So recovery from being a victim of rape follows the same steps as seen in the stages of recovery from other violent acts. Okay, here's a question for you. What nursing interventions can be used to help clients recover from violence? So let me just hear from three people. What nursing intervention? What can we do?
Refer them to social workers.
We can refer them to like what is like a domestic violence type home that can offer them somewhere else to live where they can move away from that.
That's two. One more person. What are some nursing interventions that can use to help this client recover from violence? So now, do you know the domestic violence places that are in your area that someone might go to? So if you don't, just find that out. To make sure you know that, because you just never know. Interacting with our patients, they come in for one thing and we find out, something else. And these resources are there for them. They have housing, everything available. And don't be caught off guard if it's a male, because it can occur to males and females. So goals is preventing the violence from ever occurring. So identifying mental health illnesses, identifying resources, whether or not it's medications, whether or not it's self-help groups, identifying all of these things, providing this best care for our patients. So in hopes that violence just don't occur at all anyways. We do want to always be thinking about the client's safety and ours as well, as we're interacting with our clients, no matter what that setting is. Treating victims of violence, try not to leave them alone. We may have to do one-on-one. It might not be us directly one-on-one with them, but a lot of times they will have someone else that can do that one-on-one until we get things settled. We always want to explain procedures and get that permission before we, remove covers, remove gowns, and things like that before proceeding. Allow the client to maintain as much control as possible. They, we might want to ask, well, hey, do you need a moment, before we go we've assessed and looked at, your legs. Now we need to look at your arms or your vice versa. Do we need to just pause for a moment? Then, and just let them kind of, hold as much control as they can. So preventing violence in your life, it is important to remain aware that violence can erupt in any client situation. Like we were in our area, we actually had a nurse that was actually killed. She had clocked out for the day. That's why I say be aware of your surroundings in these facilities and until you arrive to your next destination. The nurse was actually leaving from the facility on the phone with spouse and children, walking to her vehicle, and she was approached. When interacting with clients, watch for signs of growing anxiety. Y'all mentioned earlier when we first started, you all were talking, I forget who was that told us about the voice tone, looking at that body language and everything. If they appear, frustrated, you may have to just, step back, give them a moment. Seek assistance from other care providers when needed. Know who's on your team and working that day. Do not feel embarrassed to reach out. Hey, I need you to come in here, to assist or whatever. We do want to enforce professional boundaries. We're not breaking rules because we don't want to open the door for something, violent to happen to us or to our patients. Okay, that was chapter 26. Any questions?
I have one. So in one of the slides, it was saying that poverty could be like a reason for domestic violence. Like, do you find in your field that that's true, or is it just more reported in the lower income based neighborhoods or facilities?
So I would say that it is a factor because I don't know if you've ever been without it. I'm just talking from personal experience. If I didn't have, if I was unhoused and didn't know where I was going to be at, not to say I would turn to violence, but in the event I saw a means to an end to be, so I wouldn't be unhoused. I can't say that a person wouldn't have that thought. Okay, this is my means to the ends, and I am going to go get whatever that is. And in the moment of trying to get that, things could turn violent. And so I don't think that they intend to be violent, but things turn to that. Had a student, hey, parents were on hard times. This is high school children. And I think the student took me fourth block and they appeared at my door at second block. Like, where are you going? I'm on my, planning period. You should be in class. Where you going? Where you past at? So because the child told the whole story about the parents, and this was after they went to do something that they were not supposed to do. But then, going back and rehashing and sitting down and talking with, the students, because it wasn't just that one student, it was actually three, but it all led back to they were trying to help the parents out. Their intent was not to go there and be violent, but because when they got there, it was doing something they weren't supposed to be doing anyways, and it kind of just led to that. So I don't know if that answers your question. I don't know if everyone all the time intends to be violent, but if you get there and just think about someone approaching you and they're trying to take your purse, what you gonna do? You're gonna try to, are you gonna give them the purse? Or are you gonna say, get on? Just go ahead. What'd you say?
You said like with people who are like more well off and richer, they seem like.
No, I was saying I understand how you describing it.
Oh no, I was asking Miss LaShawn what she was asking, like people with more well off.
No,
yeah,
what I was saying was on one of the slides said that it's more common in poverty-stricken areas, is what the slide said.
Yeah, I feel like
and I was just asking if she agreed with that because I've seen both sides of that. Is why I'm asking that.
Yeah, but rich women tend to, they rely on their husbands more for money. So if he got you in this big house, you'll lose everything if you report him to jail versus you are already broken poor.
And that's
what I tell anyway.
Yeah,
versus, you
Yeah,
have
and
a
that's
lifestyle, you don't want to lose it.
yeah,
So
and that's what
That's
I was
why the
gonna get at.
numbers are like they are because then they're not reporting it.
Yeah, that's what I was going.
That's
That's
how
what I
the
was
numbers
getting
get.
at, Smith. That's exactly what I was getting at. Is that they just don't report it as often
yeah, they
because
got too much to lose. I mean, I wouldn't want to lose my
well,
baby
not
house
only too
either.
much to lose, but for shame of they're well known in society or
That, and
That
whatever.
then you
too.
got to think about
That
what's being
too.
reported by the media also. You know what I'm saying? It's
Yeah,
not
yeah,
so much
because
Yep.
that because
they're reporting exactly,
as mandated reporters, it has to be reported, but then what's being reported that we find out about. You
exactly.
see what I'm saying? So it goes both
Yeah,
ways
So
as
he
being what's
loses
reported at the
his
same
high
time.
paying job, and
and
then it's just a snowball effect for everybody.
and that's Smith. You hit a that's key right there because I retired from a jail, and a lot of things that were going on in the more poverty-stricken communities. Of course, we were able to release that information to the media, but occurrences of violence in, just say, for instance, I'm just going to use this for an example, USC, we were not able to release face sheets or whatever to the media for what was going on at USC or just in the surrounding areas
You
for
know,
that.
yeah, they high profile, and a lot of them pay other
Yeah,
people, to get off
yeah,
and stuff too.
yeah,
And they know, got friends in high places that keep that stuff
yeah.
covered up.
Mm-hmm.
Even when it comes to the veterans, think about the military, same thing.
Yep, they always protect them.
Okay, so let me
Yep.
interject here. So when we are voting for people in office and we're selecting, we want to keep these things in mind because these are the people that are deciding, to keep these things under wrap and not. Do I think those people are intentionally trying to be violent? I can't say that they do, but I think things turn violent because of the shame and the guilt and all those things that you're talking about. Like those babies, they didn't intend to do what they just wanted to get what they needed to help their family. Things just kind of went the wrong way. Yeah, so all news don't make the news. You're correct. And so um that unfortunately that is part of it. It just doesn't, like, okay, why are you all always reporting this about this side of town or this group of people or this community? So so you don't want to give those outlets your ratings. So why are you clicking on there, watching their stuff? Watch another show, that news outlet that shows a more well-rounded, a picture of what's really, going on in everybody's community. So again, if they don't have those ratings, then what happens? They're at jeopardy for losing their slot. So you can voice your opinion because like you're saying, it does occur. And these people, and it's unfortunate that people are in positions of power that choose to do this and show this lopsided story. But it is real. Okay. So let's transition to chapter 20. Now let's go ahead and do a Kahoot. And then we have two more chapters left, and we'll be 27 and 28. And we'll be no, let's go ahead and do 27 because we've already done the Kahoot for 26. I did the Kahoots before just to check your prior knowledge. So let's go ahead and do this other PowerPoint. Two chapters left. Y'all are rocking. So this one we're looking at inward focused emotions. So you as a healthcare provider, even if you just as a citizen, start joining your boards and seeing what board positions are out there that you can take part in. Not just your board of nursing, but there's so many, like you're saying, the prison, these places and facilities, they have to have boards. See how you can get in the door and voice your, get your voice heard. All right, let's see, here we go. We have our objectives here. So maladaptive self-protective responses. So what is it about these maladaptive things? Are they good for the long haul, or they just good for that moment in time? Maladaptive.
I think they're good for a short period of time, but they become bad, ain't it?
Exactly. So they're only just good for that moment in time. And then, that issue or that problem is still there. We don't have a real resolve, a solution for it. So then that in itself, because you have that person has that temporary, um, you know, of temporary experience of this issue being resolved and then it festering out in less than a day or so, then that eventually can lead to self-destructive behaviors within that person. So someone read this slide right here, myths about suicide.
Myths about suicide. Suicide has always been present in society, but little effort was made to understand its nature until the beginning of the 20th century. Many false ideas about suicide exist. People who talk about it will not commit suicide. One does not need to take a suicide threat seriously. Only psychotic or depressed people commit suicide.
So those are false ideas or myths. So 10th leading cause of death in the United States. Second leading cause of death among people between the ages of 10 and 34. 20% of all suicides occur in white men older than 65. It's important for nurses and other healthcare providers to be well versed in recognizing and intervening when clients, with those clients that are suicidal. Okay, someone read this one for us. Cultural factors.
Cultural factors. Culture usually includes a view of suicide, laws, customs, beliefs, values, norms, customs, and rituals may play a role in suicide.
So we want to be culturally competent nurses. We want to find out, establish those therapeutic relationships that report front. So our clients can tell you what the norms are, what's the expectation, what their beliefs and everything are. Because custom and rituals may play a role in suicide. So we need to know. So there are many social influences that affect the incidence of suicide. We do want to be aware of social changes as they may offer clues to care for clients who are thinking of ending their lives. So if we've established those therapeutic relationships, we're doing that, those check-ins with them, we're interacting with them, you'll pick up on some cues and then you can ask that direct question for, and see what their thoughts are. Was there a comment? No, okay. So characteristics of suicide. Thoughts of suicide produce many of the same biochemical changes in the body as produced by depression. So clients are filled with feelings of ambivalence, anger, aggression, guilt. Feelings are just all over the place, and so you all mentioned early on, making note of, their mood. Social dimension includes one's views of others, and then spiritual, cultural, religious, and ethical dilemmas associated with one's own demise. We want to know. We got to ask those questions because we do want to seek out solutions. So suicide victims share two major viewpoints: deep despair, poor self-esteem, and feelings of being trapped. Like there's just no end in sight. There's no solution in sight. So relief from miseries of this life and the need to connect with immortality. Like it's just no beyond that point or that situation that they're actually in. So someone read this one for us here.
Suicide has a strong effect on those left behind. Survivor guilt. Survivors often think that they could have done something to prevent the suicide. Anger may be expressed socially. The stigma of suicide is felt. The survivors of suicide, no matter who they are, must grieve and learn to heal.
Exactly. So it's just not the one that actually committed suicide. It's those that actually survive. And again, we have all these different theories, and you'll see there are a whole bunch of theories out there, and they try to figure out, why is this happening? What can we do about it? So you'll have different theories out there. So suicide in children. Suicide in children is the most often the result of family conflict or some disruption. Suicide in children usually is not planned. Any child whose attitudes, behaviors, or habits change dramatically in a short time, especially if there's some type of stressful event or situation that has went on. We want to make sure that, school nursing might be your setting, making sure that we're, picking up on those cues if a teacher brings you in and if the student comes to see you. And a lot of times you're that safe space, so they're gonna come to the nurse's station, they're gonna come see you and say whatever. And you check out everything and nothing's going wrong. And so you may want to ask those focused questions to see what's really going on, what are they thinking. All right, let me hear from someone here. Someone read this slide.
Suicide and you go ahead. Suicide in adolescents. Adolescents, especially those with low self-esteem, may consider suicide as an option for solving their problems. Factors in adolescent suicide: depression, poor impulse control, emotional isolation, dysfunctional or disrupted family. Adolescents with an anorexia nervosa have higher rates of suicide.
Okay. Suicide is a significant problem in adulthood as well. Women attempted suicide 3 times more than frequently than men. Men are more successful at completing the act. Loneliness is a factor in adult suicides. Do not hesitate to ask clients if they ever think about it. Like I say, it's part of like our little questionnaire now that we have to ask that about the food. Do you feel safe? And this is another question that we're having to ask too. As age increases, so does the rate of suicide. Passive suicide, refusal to eat, drink, or cooperate with care. Older adults tend to not communicate their intentions unless directly asked. With the older adults, they may feel that, especially that retirement thing. I've heard people say, hey, we talk about this retirement, but just think about if you've been doing stuff, practically all your life, and then all of a sudden, then you retire, you don't have that second family, that work family, you don't have anything on your schedule to do. They said, you have to be careful with those that have just retired. And actually, one nonprofit is actually creating these little hubs or things to do for people, that newly retired people, because they say after that first couple of months, then it gets old that you don't have anything to do. You don't have that work because somebody you've been with and around this work family for 30 years or however long, and all of a sudden it's just you. And so you tend to see the rates higher with them. Thoughts about suicide can be described as suicidal ideations, threats, gestures, parasuicidal behaviors, suicidal attempts. The last level is completed suicide. Motivation for successful suicide may be conscious or unconscious. So, we want to ask those questions. It seems like we're prying. It is a touchy subject, but we do want to ask so that we, in the event that they're having those thoughts, that we can identify resources and connect them with those resources. Okay, so this is suicide assessment information that we will be looking at. Is there substances use involved? Is there a history? Okay, so these are just some of the nursing diagnoses that from NANDA. Okay, I think we have a few questions here. So our intervention should be to protect from harm. Take those suicide precautions, establish that rapport with the client. When we may have to make that no self-harm agreement, if even they say that they are. So commit to, hey, let's make this agreement. If those thoughts are coming to you, remember what the agreement says, and then, I want you to hold to your end, like your agreement, what you agreed to. We need you to stick to that, so we can figure out what else, whether or not it's a lot of times too, you see it when someone's using substances and they're trying to come off of them, and they also have a mental disorder, and that part is not being treated. You see a lot of violence in acts of violence too in those individuals as well. But just seeking out those resources, those alternatives. Okay. All right, so it's Kahoot time. It's Kahoot time. We almost there. We're saving the majority of our time towards the end, you all. So we will take another break here shortly, just to let you know where we're going. But we're almost there. We're almost there. Nevertheless, I think after this last PowerPoint, we would have covered Majority, about 80, maybe 90% of our information. So once you go back through these last week's recording and this week's recording, and then the extra information from next week, you will be good for the exam. So just make sure that you're going back through those recordings now. Your notes, these PowerPoints are there. They're available. You know, your study groups, you know, you all have different things that you all do to prepare. So make sure you're putting in the time. Dr. Cutler, she will do an exam review, but it will be in the announcement section. She's the course lead. She will actually post that there, so be on the lookout for that. I know that connection thing is something serious. That's fine. You make a note of it, but just make sure you go back through the classroom recordings. Yeah, only thing we can do is just make note of it, and you know, it's one of those things we can't do anything about. I say that connectivity. Now the sun can be shining and not a cloud in the sky, and you will lose connectivity. So I'm not sure what goes on up there in that on those bandwidths or with those bandwidths. But at a minimum, just make sure it's for those of you that are losing connection. I know it seems like several of you all tonight have been losing connection. Just make sure that you're going back looking at the recording. Okay. All right. So let's Kahoot it. Let's Kahoot it. Here we go. Game PIN 965-355. Log in, at least with your initials. And here we go. I'm going to try not to interrupt and let you think it through. All righty, and here we go. www.kahoot.it. All right, so let's toggle to our last chapter. Okay, just waiting for it to open up. Substance-related disorders. Substance-related disorders. Okay, we do have our objectives. Okay. All right, let me hear from you all. Someone take 1, 2, 3, 4 people. We have 4 vocabulary terms. Let me hear. Take one and just read the definition, or you can paraphrase it.
I'll go. Substance is drug of abuse, a medication or a toxic.
Thank you.
Substance use, ingestion of any chemical that affects the body.
Yeah.
Abused substances, chemicals that alter the individual's perception by affecting the central nervous system, also known as CNS.
Substance drug abuse, excessive abuse of a substance that differs from societal norms.
Thank you all. Okay, we have 4 more terms. Vocabulary terms. 4 more people. Come on, team.
An individual depends on a substance to provide pleasure or relief.
Substance chemical dependency. A user may take his or her usual dose of the drug to prevent the onset of withdrawal signs and symptoms.
Addiction. Individuals' dependence on the substance is physical.
Abstinence, not using the addictive substance.
Great, thank you all. All right, so the use of chemical substances occurs throughout the life cycle from the fetus to the older adult. There are no safe drugs for pregnant women. Even though they allow you to take medications, it's still no safe. Even the Tylenol, there are not that many that they allow you to take, but there's still no safe medications and for sure no safe substances. Excessive alcohol use can result in fetal alcohol syndrome. Cocaine use, infants exposed to cocaine in utero have sleeping and eating problems and usually have high-pitched cries and are easily irritated. Children abuse substances too, but often the substances are legal and easily available. You know, alcohol is one of the most frequently used substance. They may experiment with the use of drugs. They may use substances in social settings for relaxation, thinking that they're fitting in. With addictions, teens are likely to become involved in illegal activities if there's addiction. Because think about their teens that more than likely don't have the means to purchase. So, how they're going to get, once they become addicted, how they're going to keep getting that substance. Substance abuse is common in adults. Substances that are abused can vary according to minority groups. They're saying cocaine is used more frequently among African Americans. I'm not sure if this is the latest evidence. Whites and Hispanics individuals prefer alcohol. So, scope of problem: substance abuse has many costs. Substance use and dependence cost society dearly. Family members, even the actual individual more so. Many deaths are attributed to falls, drownings, and burns, accidents because once they have these substances on board, they're not either they were an avid swimmer or if they were, had the perfect driving record because these substances are on board, they're not able to respond and act, how they would had they not consume the substances. It does alter your thought process, your reaction process. Alcohol is a depressant, so it depresses or slows down the CNS. So with continued use, tolerance develops, and individuals become dependent or addicted to the actual substance. So narcotics, we do make sure that even if they're prescribed narcotics, they do like want to you have the patient to use them a minimum dose for a short amount of time because of that dependency. That potential is actually there. Stimulants are another group of commonly abused substances. Caffeine. What are those? What are those little drinks? People like Mountain Dews. Anybody in here like Mountain Dews? What's that other little drink that you don't really think of as even a Dr. Pepper? I had a friend or a student that were saying something about they drink Dr. Peppers all the time and they couldn't get one. They went to drive through whatever, they couldn't get one. So they noticed like after like the second day hadn't had a Dr. Pepper because they drink one every day, that they noticed they were getting like the little fidgeting and the little shakes. And I was like, wow, from the doctor, but they consume it every day, like more than one. So I guess they were really experiencing it. But I know people say like Mountain Dew. I haven't experienced the Mountain Dew thing. Um, what else do they say? It's another one of those drinks that has high caffeine content. If you consume those all the time and you stop consuming those, you can kind of have those jitters and things. I can't think of what it is in a can. I don't know, it'll come to me.
You talking about Red Bull?
Yes, that's it. Red Bull. Yes, the Red Bull. I'm not sure how much caffeine is in in those, but it is a high caffeine content. Now I will tell you, we were driving, and you know how you stop at the little gas stations and stuff, and so I drink coffee. It doesn't matter if it's hot or cold. I drink coffee. I just like the way it tastes. And so they had the little pods that you can add to your little coffee. I like the little flavor things. And one said, what did that thing say? But anyways, it was a shot of caffeine. And when I tell you, I was like, I was like, oh my goodness, what was in that little pod? You know how you get the little flavor, the creamers and stuff. But it said this one didn't have any flavor to it. It said something about it didn't say a caffeine shot, but that's essentially what it was. I was like, oh my goodness. And I was driving and driving. I was hyper aware. It's like, oh my goodness, this stuff is bad. So those looking at that caffeine, and especially if you're sensitive to it, you want to make sure that you're watching even the Dr. Peppers and things like that because it does have that caffeine in it, and it will affect you. So users of hallucinogens experience everything from profound mind expanding experiences to what they call bad trips. So nevertheless, it does alter, people's thought processes, their responses, their response rate. So these things, they do alter the body. And these are just some different names that they have for the street drugs. Now the vapes, I'm not sure what's all in those. I don't think vapes are on these slides. And what are those things called? Hookahs? I'm not sure what are in hookahs either. I don't have that much understanding of that. But what they've said now that you can put things in there. I don't know if that's true, y'all, but just be careful of these things that we're consuming. Read them labels and ask those questions because sometimes you may end up ingesting something that you really didn't intend to ingest.
My drug of choice is food.
I have that problem too. But yeah. And so many of these medicines, we administer morphine. We administer some of these medicines, and they were developed to save lives or ease suffering. But then we found out they can also cause dependence and can lead to other things. So we just want to make sure that the patient understands how to take those medicines, every 6 hours. So we're counting every 6 hours. We don't just pop another pill if we're feeling anxious. So that's why we want to also teach and reinforce those non-pharmacologic ways of dealing with everything. We need to stop and take a break. We're gonna stop to do another 5-minute break, and we're pushing our other time to the back. So once we come back, we won't have just a few more minutes to meet. But I want to at least give y'all at least 15 minutes of break time because we do sit for a long time. So 5 minutes, see you in 5, and then we don't have very much before we finish up for tonight. So see you in 5. So that'll be what, 38, 8:38 your time? Right? Yes. Okay. All right, we're gonna finish up with this one last Kahoot, and then that to take us on to the end of class. So if you would go ahead and log in, at least with your initials. All righty, let's get ready to Kahoot. And here we go. All righty. So we say that our other time toward the end. So you all are free to go. Take care. Make sure that you attend that exam review if you can. Go back through our classroom recordings. Make sure you're looking at your required readings. We'll see you on next week. Take care. I'm here for a few minutes if anyone would like to talk. Oh, everybody logged out. Mhm. By law, we are mandated reporters. So we must report, healthcare providers are required to report incidents of violence to the police. We don't have to know all the details, but we must report it. Victims of violence may experience disturbed relationships with family and friends as they attempt to cope with their experiences and rebuild their lives. We talked about intimate partner violence. It does affect the children. It affects their development, their social skills. It does affect the children. There is a common misconception that infants and young children are minimally affected. That's a misconception. Depending upon developmental factors such as the level of verbal or either their understanding of social norms of good and bad or right or wrong, the social and emotional consequences can actually be severe. As with adults, the physical sequelae of childhood abuse are determined by the frequency and types of abuse that are actually inflicted. So we said a history of substance abuse is a personal risk factor that can increase a individual's likelihood of engaging in violent behaviors because they are seeing what they're doing, what they've seen, and the substance abuse can lead to them making decisions, bad decisions. Depression, poor impulse control, and emotional isolation are related to suicide in adolescence. We do want to ask clients directly about suicidal thoughts. That gives them that permission to discuss their feelings and attitudes openly. So we want to ask that question. Then we want to seek out resources in the event that they say that they are, having thoughts of it. Sympathetic nervous system, let's see how it affects us. So tachycardia, that person may complain of increased heart rate, and when you check that heart rate, it might actually be increased. That person may experience that dry mouth. That's what we will give them the dry candy, dry heart candy. We need them to be changing positions slowly, maybe even monitoring that blood pressure because it can have lead to hypotension. Okay. And then it can lead to urinary retention also. SSRIs can potentially increase suicidal ideation, especially in young adults and adolescents during the initial weeks of treatment. So we want to make sure that we're asking those questions, being proactive and asking those questions because those SSRIs that first week, it could increase suicidal thoughts. Lexapro is considered SSRIs like Lexapro are considered first line for GAD, generalized anxiety disorder, and that's because the side effects are not as bad compared to those benzos. So it's an SSRI like Lexapro, or usually you will see those prescribed first. So we do want to be careful with the natural. The St. John's wort can interact. It potentially cause serotonin syndrome. So they need to let the doctor know what vitamins that they're actually taking because they could actually potentially cause them even more harm. Lithium can cause polyuria, which is excessive urination, due to its effects on the kidneys, which can lead to dehydration if it's not properly managed. We don't want them to be using extra salt on food also if they're taking lithium. Benzodiazepines can interact dangerously with alcohol and cause withdrawal symptoms if stopped abruptly. We want to remind our patients to take their medications as prescribed, and if they're experiencing any side effects or anything, that they just need to let the doctor know so that the next steps can be decided. Because if they stop some of those medications abruptly, it's going to cause them even more harm. MAOIs can interact dangerously with tyramine rich foods like those cheese. I think even sardines are an example. So we want to make sure we do that, gather information about their food history, because we don't want them to have that interaction, and it could potentially cause a hypertensive crisis leading to stroke and heart attack. Maladaptive behaviors might include drug and alcohol use, indicating a more comprehensive approach to recovery. So we said maladaptive behaviors, it appears that there's a solution, but it is short-lived. And so it can, have a profound effect, a negative impact on this person improving. Emphasis that treatment also involves helping individuals develop new behaviors that do not include drug and alcohol use. We want to identify some non-pharmacologic interventions, help groups, if they have a certain hobby, playing music therapy, pet therapy. And so that will help this patient develop new behaviors in how to cope instead of using those drugs and alcohol. Having a specific plan for suicide indicates a low level of intent and is considered a severe risk for suicide. This statement is false. It indicates a high level of intent. Having a specific plan for suicide indicates a high level of intent and is considered a severe risk factor for suicide. Treatment-resistant depression can lead to increased feelings of hopelessness and a higher risk of suicidal ideation. Let's look at different factors now. We have occupational factors include job-related stress and access to controlled medications, which are particularly relevant to healthcare professionals. Genetic and biological factors encompasses family history of addiction and chronic pain, conditions that may lead to substance use. Then we have environmental factors, everything that's in that environment, and it does include peer pressure. Psychological factors include pre-existing mental health disorders that may increase the vulnerability for that person to misuse substances. So we talked about these 3 meds. We talked about these early on. So we have the fluoxetine, treats depression and can help certain anxiety disorders. We have the lithium. It stabilizes that mood. It is the first line for bipolar disorder, especially to prevent mania. Lorazepam is used for short-term management of acute anxiety, including panic attacks. Healthcare providers, we need to know about lithium use due to its narrow therapeutic index and potential interactions with other medications. So we need to be asking, what are they currently on because of potential interactions with other medications. We know about those vitamins and all the supplements that they're taking. What can help patients manage panic attacks and reduce overall anxiety? Okay. Teaching those relaxation techniques and encouraging them to exercise, to journal, do deep breathing. All of these can help that patient manage panic attacks and reduce their overall anxiety. Obsessive compulsive disorder is characterized by persistent, intrusive, and distressing thoughts that cause significant anxiety or distress. And this can lead to the person not being a productive citizen. It can lead to that person not being able to take care of themselves and those that they're responsible for. Okay, so the environment should be calm and low stimulation when we are doing an exam. The environment can help reduce agitation and prevent escalation of any manic symptoms. So we want to make sure that we have a calm, low stimulation environment. This office or this place that we're doing the assessment probably should not be near an open entrance, because entrances, that's going to be a high populated or visited high traffic area. We want to make sure that we have that low, calm, stimulated place. What should the nurse do when a patient is challenged with negative self-talk? We want to help the patient identify and challenge negative self-talk. It's going to be a key component of cognitive behavior interventions for depression, promoting more balanced and realistic thinking patterns. We want them to have a more balanced thought. So we have them to, cast down those negative thoughts.